The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
So our Code Blue team was formed in 2013, and we had the objective of developing basically a methodology to retrospectively review all the inpatient true Code Blues to understand the factors which contribute to the event. We defined true Code Blues, all the events where we had to bag and mask, ventilate patients for a respiratory arrest, or we had to perform CPR. We have a meeting monthly, similarly to the Western Hospital, and the committee or the team consists of several members of the senior medical staff and the nursing staff. We are fortunate enough to have the Director of Medical Services as well on our side, and he's a keen contributor to the team. We basically perform a standardized case review of all the events with descriptive analysis of each event. We have no financial interest to declare, but I would like to say special thanks to Mandy, who is our Director of Service Development, because she played a major role of creating the group, and Fiona Tweedley, who is our Standard 9 officer and doing all the data collection for us, basically. So what are we focusing on? We focus on the preventability of all these arrests. We would like to see whether these events are preventable, and we would like to see whether the activation of the Code Blue is preventable. 2016 was the first year when we actually added the acute areas, so the emergency department, the ICU, and the operating theatres to our review process, because it's very important to track all these activities in the Alfred Health, to see whether patients continue to deteriorate once they are not on the ward. What do? We basically review whether the patient met clinical review criteria or medical criteria in the 24 hours prior to the code, whether they had any missed med calls, and we in details have a look at all the events, whether they had any documentation issues, handover issues, whether there were any medication-related issues, whether there were any incidents which actually resulted in deterioration in the patient's state, and whether there were any palliative care issues. We published our previous results before 2016, so this paper does not consist of the acute areas. We try to be methodological, so we classify the potential preventability, and we identify whether there were any issues with medical or nursing interventions, whether there were any issues with equipment, whether there were any process issues. These three criteria are identified when we try to review whether the actual deterioration was preventable. And regarding the Code Blue activation, we want to have a look whether the Code Blue was activated despite having an NFR form in the chart, or whether it was activated because there were no discussions and we all felt that it was not appropriate. So how did we do? We had over 8,000 Metro Code Blue activations in Alfred Health, which is across 3 hospitals. It's still a very high number. Almost 700 Code Blue activations. This includes the outpatient Code Blues as well. And of all these activations, the true cardiopulmonary arrests were 99 cases. We do have neonatal codes as well, but we do not review those because that belongs to the Women's Hospital. So overall, 88 Code Blues. That includes the acute areas. And as you can see, very few cases were actually preventable despite the very detailed review. We introduced the medical emergency team system in 2002, and you can see that the numbers are tracking up and up and up. the mandatory system was introduced in 2012-13, and since then the numbers are radically higher. Well, at the same time, it is obvious that the code blue numbers dramatically decreased. Now, these activations per 1,000 admissions, these are total admissions, so these include the single-day admissions as well. The literature most of the time, however, quotes multi-day admissions, so if we recalculate the numbers, last year we had 1.35 code blues per 1,000 multi-day admissions, which is very comparable to other tertiary hospitals and a lot better than most places. Based on the recent review, which Gerard Fennessy did, or David Jones published a paper on their own data from the Austin. The unit numbers probably don't say much to you, but you can see that most code blues occur in monitored areas in our hospital. So the cardiology, cardiothoracic wards have most of the arrests. And the other wards, a cardiac arrest or cardiorespiratory, is actually extremely rare. So if I want to show the numbers, out of the 88 arrests which we had last year, only 14% were preventable. 4% is still not determined because we are waiting for coroner's report, or we feed the cases back where we need to clarify some questions to the home teams, and we are waiting for reports back on those cases. So those are the deterioration, whether that was preventable. When we have a look at whether the code, calling the code was preventable, it's a slightly higher number when it was potentially preventable. So that means that the code was called when there was an NFR form was filled out, or there was no discussion despite obvious futility. The pre-arrest resuscitation status in almost half of the cases was not complete, unfortunately. So even though this is a very low number of code blues, there is always room for improvement. In the 17 cases where we identified some potential problems or areas of improvement, 7 cases were identified as where there was no there was a code blue called and CPR was performed despite having an NFR form. 5 cases where the code was called and there was no discussion previously, but there was obvious futility. And there was only 1 case where there were potential issues identified with an intervention, and 4 cases where there were potential process issues. So very low numbers. And I spoke a lot about how most of the cases are not preventable, but despite the fact that most of the cases are not preventable, the survival rate is very high in our hospital. The literature reports a mortality rate between 60 to 80%. Gerard Fennessy's review reported a 75% mortality of in-hospital cardiac arrests. Our mortality rate is 55%. Which is a lot better to compare to other hospitals. The potential causes for this improved survival, I'd like to think that our mandatory MET system can prevent a lot of the deteriorations. As you can see, this is just another way of looking at the calls. This is just the Alfred Hospital, where we had over 6,000 calls last year, which practically 20 calls a day. You would like to think that it does make a difference. And the number of calls is a lot higher than in the ANZICS registry, so we have 6 times the ANZICS median reported calls. Also, just like most of the hospitals, we have a very robust BLS hospital teaching program. I think it is very important that we have a 24/7 ICU on-site consultant cover. So, and it is not a written expectation, but a general expectation from the hospital that we do show up on all the code blues on the wards, and all the consultants are ALS trained. Also, we have an ECMO CPR service. 19 cases last year ended up with a ECMO CPR, and of those, nine people were survivors. When we have a look at the data, it is possible that we capture some of the captured data doesn't actually reflect true cardiac arrest, as 16% of the cases had only one cycle of CPR. So it's impossible to tell retrospectively whether these were just syncopal episodes or non-sustained arrhythmias. Because they received CPR, they still show up in our registry. Regarding the rhythm, our data is very similar to the national average, where 30% of the rhythms is a shockable rhythm. And most of the arrests coming from the from monitored areas or witness cardiac arrest. So overall, our Code Blue review group doesn't support the hypothesis that all true Code Blues are potentially preventable and a failure of our systems, because that's very different to our findings. But we do identify several areas that need improvement, and there is always room to improve. So the future focus will be ongoing work with the end-of-life committee. We do feedback all the cases to them where CPR was inappropriate. We do need to do a lot of work in the acute areas, as the reporting is potentially missing some cases. We only started to report the cases last year from the acute areas, so we need to constantly encourage them to report the code blues from those areas. And we still need to work on our methodology, so our data collection can be improved just to identify more easier which arrests were witnessed or non-witnessed, which arrests are coming from monitored areas or non-monitored patients. One of the areas of work is the development of hot debrief guidelines, as these arrests are extremely rare now on some wards, and we do get calls from the wards that the nurses are actually quite traumatized after and the junior medical staff after a true arrest. And because of the nature of our work, the shift work, it's very difficult to organize a formal debrief sessions a couple of days later. So what we try to do, we try to just develop these hot debriefs when we go back an hour later and try to talk to the staff who were present at the arrest. And it would be good to work on the long-term follow-up on the in-hospital cardiac arrest survivors, which is actually not done at the moment in our hospital.